Could I ask you to stay up and our speakers to come up as well and take a seat for a question session? I'd like to thank all our speakers for excellent talks and also for keeping to time. We started about 5 minutes late, but we've got back on time. Mainly thanks to Hanu there, who cut us things in 5 minutes. So, do we have a microphone to hand around?
Yeah, I have.
Yeah, here we are. So, any questions from the audience? Do you want to keep this part down for the answer? Oh, then we're behind you guys want to give us where Bill's going to ask.
I have.
Thank you. I'm not sure this is working. Is this working?
No.
I really enjoyed all the talks. I guess I'm not sure this stuff is working either.
We can hear you. Speak.
Okay, but is it working in the back?
This one?
Yeah. I'm afraid of this one now. Tremendous talks, and the focus on anatomy is absolutely the right thing. I'm Bill Myers from Philadelphia, and I want to, in era, just to mention Adam Zoga is really important. I encouraged Adam to steal cadavers down to the MRI suite in the middle of the night. I had nothing to do with it, and even though a technician caught them, to be able to develop the MRI imaging techniques and to apply this into anatomy and what Stephanie and Sonia applied is really nice. And I want to throw one concept by you all and see what you think. In my dissections and fresh cadavers, we've been able to separate this big fibrocartilage glob, this cover, from the pubic bone, and you can actually create spaces, but it has to be fresh cadavers, and it can't be real old cadavers, and that's the space I think where you're seeing most of the fluid, and it can crack like ice too as you're dissecting it out, so you can get different planes that occur, and we followed several players, runners and basketball players primarily, where the fluid eventually it starts out there, and then eventually with continued playing and no surgery would cross the cortex and get into the pubic bone and create then the marrow would light up. Couldn't this be a part of the process of osteitis that we talk about when we talk about osteitis? Couldn't be like the ankle joint where you get arthritic changes, et cetera. And couldn't you take the concepts of tendon and a lot of the tendon you're seeing, and you showed, I think, Sonia, in some of your slides, that there's more muscle than tendon there. Couldn't I'm not sure, was it Stephanie? Couldn't all this tendinous stuff be really part of that plate? And we should be talking more about the cover of the baseball, or cover of the entire pubic bone there, as opposed to tendinous structures. It helps a lot surgically in terms of what I do technique-wise.
Well, I think absolutely. I think that's why this terminology is very confusing, and the term that I threw out there, this prepubic aponeurotic complex, I think of it as a combination of these tendons are there, then you have the capsule, and then as we saw that some of the tendons actually have attachments to the capsule, to the bone, to the periosteum. The cartilaginous component, I think we haven't demonstrated that very well on imaging, at least that anterior portion, and maybe we should look at that a bit more closely from an imaging standpoint. But I think I personally need to be more familiar with the gross anatomy to know what to look for.
Yeah, I mean, I think, as you say, in sports injury, everywhere you see injury is usually at a junctional area where there's two different. So muscle injuries, it's not really a muscle injury; it's a myotendinous injury because you've got the differential between the muscle and the tendon. And I think what we're saying is the same thing. We're saying that the capsule and where the adductors meet and where the rectus abdominis meets is the area that seems to undergo stress. And certainly years ago we used to call it, because in Leeds we have a massive rheumatology, research component too. We used to call it enthesopathy. And I think, in hindsight, that's wrong because it kind of implies that it's where the tendon goes into its insertion, but I think the tendon almost isn't inserting into the bone, it's actually attaching to that fibre cartilage and that capsule, and you're getting a stress across that area. So I think things like tendinopathy and enthesopathy are probably terms we should move away from. And think about this junctional area and what we call it, plate or capsule junction area, I'm not sure. Kerry, you have a question?
Thank you. Again, great presentation. Thank you very much. It's a question to, I guess, both to the anatomist and the radiologist. The insertion of the adductors now. I was reacting to Phil's comment that they're not inserting into the bone.
Okay.
But I mean, they are actually quite strong muscles, and they are inserting into a fibrous plate that are inserting into a capsule that are inserting into a bone. So what would be the anatomical interpretation from the anatomist? Are the adductors, being these strong muscles, having this strong power and action, are they really inserting into the bone, or is it an indirect insertion, and how can we interpret that, and how does that look on the imaging?
Okay, thanks. I think from just the little bit of histology that I've done is that they certainly do insert into the bone with a fibrocartilaginous enthesis, which is pretty strong, as opposed to a fibrous insertion. So they definitely do, but they also have the portion of the tendon then blends with those capsular tissues, from my understanding. And so you're right, there's really strong tendons. So I know, I guess it comes back maybe to what Anthony was talking about yesterday about the biomechanics and what are these muscles, exposed to, and therefore where are they mostly going to be injured. But I think just listening to the plate idea, it would be really nice to maybe look at the layering system, maybe using histology or something to actually see what those different layers are, because they seem to be so intertwined and really difficult to separate. So whether or not that might be useful kind of moving forward.
It's not working. We'll come back to you in a second.
Recently, I review all MRI, not all, a lot of MRI that I have reported before, and really I changed my mind. Because, so before we looked at the attachment, at the bony attachment of the adductor longus, any edema, anterior edema of the pubic symphysis, we reported as pubic osteitis, something like this. I'm sure that this is more tear of the attachment, the capsular attachment of the adductor longus. Yeah. So I repeat. So I reviewed a lot of MRI that I reported, and really I changed my mind because I think that we focused at the bony attachment of the adductor longus. However, after the Robinson study, we have to focus at the capsular attachment of the adductor longus. A lot of edema, capsular anterior edema, reported as pubic osteitis. I'm sure it's more related to injury at the adductor tendon attachment, capsular attachment. For that, we need to optimize sequence and to do, it depends on your clinical examination. If you ask me that the patient has pain with the pubic tubercle, I will optimize my sequence, and for sure we can, be more, efficient in the location of lesion.
Hi, my name is Leandro. I'm from São Paulo, Brazil. Thank you for the great presentations. I have a question to Dr. Kasarjian. You briefly mentioned about the Flamingo views. I'd like to know if you use it routinely or just in specific situations.
I don't use it routinely.
No?
No. The main reason is I primarily focus on MRI, so the patients usually come with all the imaging studies, those imaging studies done. I do believe that there may be a role for it when the specific clinical question is whether there's instability. And it may be useful to just add another data point to the clinical examination to say, well, clinically, there might have been some instability, and this is just one more data point to support that diagnosis. But in my practice, I don't use it routinely. I think in Philadelphia you do. Not routine.
Just like what you're saying.
Okay.
Sorry, do you have a...
Professor Griffiths had his hand up the longest.
Has he? Okay.
That's all right, thank you. Very interested to hear about the superior cleft and also the potential relationship of that with the underneath of the plate. Do you think that the superior cleft and the secondary cleft are in the same plane? And if so, do they connect, therefore, with the primary cleft and therefore are deep to the capsule of the joint? Or are we talking about a bunch of different things?
Me again, or you?
Yeah.
Well, personally, I think, if you look at coronal images, you will see a connection between those clefts and the primary cleft. That's, in a way, the way they have been defined. You can see that you can follow them from the primary cleft and out, either inferiorly if it's the secondary cleft, or more superiorly if it's the superior cleft. Now, what do they represent? I think, personally, I think it's difficult to say, really, because when you look at MR images, there are a lot of things going on in this particular area. What is capsule? What is fluid? And where is this fluid exactly located? If you were to look at this patient in real life. I also think it's difficult when you look at the dissection pictures, where you can see that there are so many ligaments and it's very tightly bound, and it's difficult to sort of get an impression of where is this fluid actually located, where does it go, and I don't know if any of the other speakers here have an idea about that, but I think it's also part of the controversy about this. We don't really know what these signs represent. Are they signs of a lesion? Is it because some tissue has been resorbed? Is it because there is a crack, a sort of tear? I don't really know if anybody has an answer to that. They have just been described as pathological, radiological findings because we can see them on the images. But I don't think, I won't speak for the others, but maybe the others know what they represent. I don't think anybody has really given a proof of that.
I think I agree. I believe that from what I've seen, they are related. And so whether they're anatomically distinct entities or just different components of one lesion, I think it's hard to say. I think we're starting to expect too much out of MRI sometimes, at least at this stage. These fibers, when you dissect them, excuse me, are very difficult to dissect because they're actually just all meshed together. And it's a very meticulous dissection. Even then, sometimes you can't clearly define the layers. And if you can't do it at dissection and you're asking us to do it at MRI, I think we're trying, but I think it's definitely a challenge. As we advance, as we heard earlier, with the stronger magnets, and I think even more important might be the coil technology. We can get these microcoils, the surface coils, and really focus in, then maybe we can get the true correlation between the good anatomy with good dissections, the high-resolution imaging, which we may have to do in cadavers first to get the high-resolution imaging, and then translate that to try to understand the findings that we see on our routine MRIs.
Yes, and another of the problems is that the cadavers that have been dissected don't necessarily have a superior cleft or a secondary cleft, and you can't pick somebody and dissect them afterwards to have the gold standard. And I think that's really also one of the problems of finding out what this really is.
How often you see this in asymptomatic people, this secondary cleft sign?
Well, for example, in the study we performed, we did not find many secondary cleft signs in any of the groups, but we did not find any significant difference between the groups either for the secondary cleft sign. So that's why I'm also a bit, I don't know what it represents.
We found it particularly in players that have had no groin pain ever. And I routinely see it in a lot of professional players that come back with other symptoms. You can still see it's there. So whether it heals to go back to imaging normality, I think is probably it doesn't, but that's the same for the rest of the body. You look at the rotator cuff in the shoulder, it never looks normal again, and I'm sure it's going to be the same for the groin. And I think just more and more athletes are imaged. Professional athletes are imaged, and we're just seeing more. So we're seeing anything that comes with a hamstring injury. I always have a quick look at the groin, and you can see clefts, and they're completely asymptomatic. But they've had groin pain previously. Any other questions? I think this chap here has been waiting as well.
So thank you for these brilliant talks. I have a question concerning the subspine impingement and the imaging modality you use for the subspine impingement. Yesterday morning we had an excellent talk about the frequency of the avulsion injuries, especially in the inferior spine, and that it's the most often modality there. And the question focused on the imaging modality. Do you use CT scan like you showed with three-dimensional imaging like the classification which is published? Or what is the imaging criteria in MR scan for a subspine impingement? What images planes do you use? And what is the criteria? When did you think about subspine impingement in MRI?
So let me take this in two steps. The first, the initial diagnosis, and when they have the acute injury, these young athletes, I think that MRI is the way to go. That's where you can really see the anatomy of the injury, whether it's actually a avulsion of the apophysis, if it's a mild tendinous injury, or if it's, you think it's a rectus femoris injury and it's an iliopsoas injury, or vice versa, like we heard yesterday. Once you get to the stage where they're having impingement symptoms, usually, at least in my practice, they come in with a question of, if they're having femoral acetabular impingement. In those cases, our routine is to do MR arthrography. During MR arthrography, if we see this osseous protuberance, or if you've seen on the x-rays that were done to look for the cam lesion, for example, then that's where you have to go back and discuss this with the surgeon and say, there is or is not a cam lesion, there is or is not a labral tear, but we also see this osseous protuberance. And if it's something that is going to potentially be addressed surgically because it's large enough or it may be a component of the impingement, I do think at that point it's good to do a CT scan. I think you get a better sense of the true osseous anatomy and the curvature and the elongation, its location for operative planning. The classification system, there's a paper on that. I think classifying these lesions is a bit difficult because no two are the same. But the key for me, at least and with my surgeons, is that the location, configuration, and size may differentiate between doing a strictly arthroscopic procedure or doing a mini-open procedure or an open procedure based on some of the surgical preferences, techniques, or just a matter of exposure.
Okay, well, I think we'll draw this part of the session to an end for a coffee break now, so we'll come back in 20 minutes or so, 10:50, and thank you.